Good afternoon. My name is Olufunso Odunukan, fellow in training, and I am here with Dr. Feinberg to talk to him for the FIT blog. Feinberg, welcome.
Good afternoon. Nice to be here.
Can you tell us a little bit about yourself?
Yeah, I'm a cardiovascular and thoracic surgeon. I work in South Louisiana. I work with a large group of cardiologists where we have about 200,000 patients in our practice. It's a multi-center practice, so we cover a broad area in South Louisiana. And I'm very active in our structural heart program. I'm also very active, obviously, as an operative cardiac surgeon.
Can you walk us through the growth and evolution of structural heart issues, particularly TAVR programs, the trans-aortic catheter replacement?
Now, I think the TAVR is a great technology, but in order to really apply it effectively, you need to have a collaborative team. All structural heart, I think, eventually, you need to have strong buy-in from your surgical team, as well as the community and cardiologist. But I think the challenges are that it's collaboration. I like to say, and I tell this to my teams, collaboration in the new millennium, collaboration is the new competition. Those surgical teams and medical cardiology teams that can collaborate the best are going to be those that bring the newest technology out soonest, most effectively. There's been a great deal of research done by Dr. Bomer, Richard Bomer, and Pisano. I think it's Dr. Pisano at Harvard Business School. They did some work in the late 90s and early 2000s looking at learning curves, particularly then with the heart port system, which was a surgical system for doing minimally invasive heart surgery. But what they showed was learning curves were best or steepest or dropped to zero fastest in organizations that had the highest and most effective level of communication in and amongst the team members. It was independent of the device design. It had to do with how well team members collaborated with each other. And that's because you come from a time when people sort of have their own silos. You have your surgery team over here, your cardiology team over here, and so you need people to collaborate vertically as well as horizontally and feel free to have those kind of conversations and discussions. So we make sure our teams that everybody in the team is important, everybody knows they're important, everybody's opinion matters. So when you see things that don't go like you think they should go, everybody has a right to sort of speak up and everyone's listened to. And we deployed, we've done over 100 TAVRs so far at our center, but we did not have a death in our cath lab from a TAVR until our 83rd case, which I think is attributable to our quality of communication because it was a study, so we know case selection was the same across the whole study. And I think what's different in our center, what made us have low early mortality and early morbidity relative to our center with those kinds of incidents, that is on-table death, was the quality of communication in amongst our team members.
Excellent. I'm in total agreement that TAVR is a disruptive technology and its strength is hinged on how well the heart team works together. But tell us, what are some of the challenges you've encountered working with cardiologists in the heart team?
The challenges, of course, are the real challenges are communication, and I think at least in our setting, it's been an issue of understanding turf and understanding that the patient belongs to everybody. And so what you have to do is what's best for the patient, not what's best for your specialty or your own little area of the world. And I think that's, you talk about disruptive innovation, and that, Clay Christensen, who wrote that book, Disruptive Innovation, Why Successful Firms Fail, is a professor at Harvard Business School as well. And I think this truly is a disruptive innovation. And those of us who sort of in that low area at the bottom, and if you remember his theories that low-end users, those of us that are excited and interested in collaborating, eventually we take over. And what I think you're going to see happen, in my own prediction, regulatory issues do interfere with free market, of course, but I think you'll see a new kind of specialty evolve over the next decade, and you're going to see an interventional cardiologist or surgeon. It's someone that's in between, a doctor for the hybrid OR, that has training and skills in both. And that's what I'm excited about it, because and my mother, I'm old enough to have a mother who was a nurse in nursing school in 1939, and I can remember my mother's passed now, but I remember her telling me that penicillin was kept under lock and key in 1939 because it was a new technology and a new drug. So where we've come and where we're going is almost unfathomable.
Tell us a little bit more about where you see things evolving to in terms of the hybrid OR. Tell us
Well,
about
I really think that the hybrid OR gives us some unique opportunities for disruption and for innovation, because you're going to see cardiologists and surgeons working together in the operative environment, which I think opens up the whole field of coronary revascularization, because right now you've got the cardiologists do stents and balloons, the surgeons do bypass. Well, what about all these patients who've had multivessel stents, multiple coronary surgeries, and they still have recurrent angina? And, you know, I think there's an opportunity. I think there's enough new things on the horizon. I'll give you an example. Dudley Johnson, I don't know if you're familiar with Dr. Johnson, but years ago he did a lot of research on coronary endarterectomy, and he did open endarterectomy. It was an extensive operation. Obviously, it didn't catch on because it's not being done in the way Dr. Johnson anticipated. But there are things we didn't have then. We didn't have the type of intracoronary devices we have today. We didn't have the type of medical support like the antiplatelets, like Plavix, cyclopidine, that do to help with stents. So I'll look for the birth of operations for patients with extensive coronary disease who are otherwise not candidates for either therapy alone, but you'll see a hybrid therapy be applied to them with both the surgeons and cardiologists working at the same time to completely revascularize the heart.
Excellent. Well, Dr. Feinberg, thank you for spending time with us. It's been a pleasure talking to you. We enjoyed every minute of the time spent with you.
Thank you. I certainly enjoyed meeting you and you guys. Good luck. Enjoy the meeting. Enjoy San Diego.
Thank you. And for the FIT blog, this is Olufunso Odunukan for FIT on the Go. Thank you.